Today we're going to talk about acute respiratory distress in the emergency department. Specifically, we're going to focus on treating asthma and COPD. Now, respiratory distress in the emergency department is kind of like the sunrise. You can be pretty sure you're going to see it every day. Now, that being the case, we need to be able to determine what type it is and how to treat it properly. We're not going to go deep into all the patho and anatomy behind these disease processes. There's some great lessons here on nrsng.com in our MedSearch sections, so if you guys need a refresher, go check them out. That being said, we do need to remember that asthma is a disease of triggers. Something caused the exacerbation your patient is having. Now, it could be dust or pollen, a new floor cleaner. It could even be something in the ED itself, a new medication, a strange perfume that kind of wafts by. The point is, these exacerbations are caused by some sort of external factor, something like these wonderful little microbes over here. Anyway, COPD, as we know, is a combination condition. It's usually a patient who has a combination of chronic bronchitis or emphysema along with the asthma. So, guys, we know asthma. We've seen asthma. So let's review some of the symptoms pretty quickly. These patients are going to have that telltale wheeze, which usually starts as an expiratory wheeze and then changes over to occurring both during inhalation and exhalation as the disease process progresses. They could have that intractable cough along with the accessory muscle use, and it's no surprise, with not being able to breathe at all. So now they can't breathe. They're sucking air. They're getting more anxious. Do we think they can talk well? Probably not. And if you grab your stethoscope and listen to their lungs, well, guess what? You're not really going to hear a lot of that air movement at all. Our COPDers now. Well, when they're having that really good exacerbation, we can see it. They're going to have some of that difficulty breathing, that rapid breathing, and their O2 sat is probably going to be dropping. If we can get a sputum sample, we're going to see changes in the color, that kind of brown, green, and if they've been coughing for a while, you might see a little red in there, that hemoptysis. Grab your stethoscope, and you're going to hear all kinds of fun sounds, rhonchi, wheezes, crackles. Make sure that when you're documenting, you document where you hear these things, upper lobes, lower lobes, left, right. If we watch them, these are the patients that have that classic pursed lip breathing, the pink puffers, we've referred to them sometimes. They're basically trying to blow off CO2, carbon dioxide. Like our asthmatics, you're going to see those kind of sternal and clavicular retractions as they're using their accessory muscles. And as this progresses, as they get worse, you're going to start to see some jugular venous distension, that JVD, and some hepatomegaly, the enlarging of the liver, basically because the blood is starting to pool out in the vasculature. Now, obviously, we need to treat them. So with our asthmatics, start simple. Position of comfort. However they want to sit, let them sit. This is not the time to tell your patient, you need to lay back in the bed, sir. Look, whatever they need to do to facilitate their breathing, let them do. You want to try to get a little information if you can, if they can actually talk. You want to know, how long has this been going on, right? And if they've had any previous exacerbations like this, and really most importantly, have they had to be intubated for a previous exacerbation? Because it usually indicates that they might need that again. While you're getting this info, obviously, treat them. Get some oxygen on them with a non-rebreather. Get that IV access. We can hook up the nebulizer actually to the non-rebreather. You can hook up a nebulizer mask and give them the albuterol, the Atrovent, the nebulized meds. Try to open up that airway. Now, keep an eye on the heart rate when we do that, because those nebulized bronchodilators tend to cause a little tachycardia, so don't be surprised. You want to try to get a peak flow if you can before and after treatment. And the reason for that is you want to see if what you're doing is actually helping them. We can consider IV medications like mag sulfate, steroids like solumedrol, and obviously if all of this fails, if nothing we're doing is working and the patient's losing their airway, we're going to have to intubate them. Our COPDers are a little different when it comes to treatment. Now, we want to keep an eye on the O2 sat, but remember here, guys, 90 to 92% for a patient with chronic COPD is a pretty good number for them. Now, we want to get some oxygen on them to maintain that saturation. I know. Professor Mike, What about the hypoxic drive and not giving oxygen to a COPD patient? Listen, this is the emergency department. The amount of oxygen we're going to give them is most likely not going to kick in the hypoxic drive. And frankly, if their set's dropping to 80 and 70 and 60, we got to get it back up, right? Never withhold the oxygen. We can't live without oxygen. Remember that. So yeah, don't withhold oxygen here. Like our asthmatics, we want to open up the airways with some of those nebulized bronchodilators, give them the albuterol, the Atrovent. We've probably already got IV access at this point, so we can get them some steroids, possibly some antibiotics if they need it, if we think there's an infection brewing. We also want to bust out the positive pressure ventilation with our BiPAP machine. And basically, this is going to blow off some of the fluid in the lungs. And we try to do this before getting to that intubation point. And of course, just like our asthmatics, position of comfort. With these guys, high Fowlers, that bed raised up is usually the best bet. As with everything in the ED, guys, we need sound clinical judgment. We need to be able to identify the disease process and treat it accordingly. Now, with both of these conditions, right, we need to always be thinking about getting them oxygen and making sure their SATs are where they need to be. So a few key points. We need to identify the disease process in order to treat it. Right? We have to know what we're dealing with. We never withhold oxygen on these patients. They need oxygen. You need oxygen to live. You need to know your medications, as always. You need to know what's going to help them, and what you're doing is going to provide benefits. Let the patients choose their position of comfort. I assure you, if you do that, it's going to help them breathe and make them feel better. And of course, if all else fails, if they start losing their airway, be prepared to intubate them. It is the last resort, but it is on the table. So thanks once again for joining us for this quick lesson, guys. Please check out all the other emergency medicine topics here on nrsng.com. And as always, happy nursing.